Okay, so thank you for joining us at our 2023 Bioethics and Social Justice Summer Institute. This is a panel discussion on harm reduction in Catholic hospitals. And today we have three panelists. Our first is Dr. Renee McLeod. She's a DNP and a PhD. She's the director of the Division of Medical Ethics, Department of Medicine in the Northwell Health System, also vice dean and professor of the Hofstra Donald and Barbara Zucker School of Medicine at Hofstra and Hofstra University Bioethics Center. Next, we have Dr. Marcia Gardner, a PhD and RN. She is the dean of the Barbara Hagan School of Nursing and Health Sciences here at Molloy University. And then we have Dr. Anne-Marie Paraszczuk. She is RN and EDD, Molloy University Professor of Nursing, also from the Barbara H. Hagan School of Nursing and Health Sciences. I will be the moderator of the panel. My name is Kimberly Engels. I'm Associate Professor in the Department of Philosophy here at Molloy. So to begin, I'd just like to ask all three of you to just introduce yourselves a little bit further. Maybe take just a minute and talk about the kind of work that you've done and the kind of work that you do that you're bringing to the table here to have this discussion of harm reduction today. So Dr. McLeod, can we start with you?
Sure. I hope that you all can hear me. Well, I'm going to share with Dr. Gardner. Thank you, Dr. Gardner. So I always say I'm a nurse first. And as a nurse, we are present. The work that I do is very complex and very patient-centered. I'm an ethicist, and I'm a nurse ethicist. And that means that I get to be with people when they make their most difficult decisions. We take for granted health and illness, and we believe that people make decisions the way clinicians and nurses do. You know, we've been grounded in science, and there's an art to nursing, and there's a science in nursing, but patients make decisions emotionally, relationship-wise, functional-wise, psychospiritually-wise. And I'm so glad, Kim, that you brought the three of us to talk to us about this, because moral agency, moral philosophy, is inside of all of us, and we're all very complex. So the best part of my work is doing that with patients and teaching that to nurses and others.
Excellent. Thank you so much. Dr. Gardner?
Yeah, again, I'm Marcia Gardner. I'm the Dean of the Barbara Hagan School of Nursing and Health Sciences. And my clinical background started as a nurse in the neonatal ICU in what would be considered now a level 4 neonatal ICU in another state. And out of that work evolved my interest in children's development, particularly their development as it interfaces with families, and particularly medically complex and developmentally vulnerable children, such as those who might graduate from the newborn ICU, or such as those who are born with a variety of different kinds of conditions that impact both their development and their family. So I have been in higher education for quite a long time, and I've tried to marry my clinical background and my research interests in children who are medically complex or have developmental vulnerabilities with higher education by focusing on how we teach students about these very complicated issues and how we prepare them for the types of situations that they will face as clinicians, both new and experienced clinicians, and helping them to know the kinds of questions they need to ask of themselves, their practice environments, and others, so that they can help clients and patients to sort out these very complicated medical situations that they may find themselves in. So that's how I came to this. I also do, because I was doing research in that area, I completed a program in pediatric bioethics. So although I'm not an ethicist, I do have a particular interest in that sliver of bioethics.
Excellent. Thank you. Dr. Paraszczuk.
Hi. Yes, so I have been a registered nurse for quite a long time. I'm more recently, I would say, in academia. I have kind of about 19 years ago, but I had quite a long career in clinical practice before I came. So I also started in the neonatal unit back in the 70s, when the neonatal unit isn't what it looks like today, for sure. Much more advanced at this point. And all of my experience has been with parents and children. So all of my experience has been in some aspect of maternal child health. So besides neonatal, I have also worked in maternity and in pediatrics and pediatric intensive care unit. So, that's kind of really, it's always been for me, not just the patient, but, it's the child and the family, that needs to be considered. And, I came into nursing at a time when family-centered care was sort of coming into being, and I remember very distinctly how the older nurses that I worked with, poo-pooed it. It's like, what is, they didn't want the parents there, they really resisted. And so I had that experience. And so, from that experience, family-centered care has been an interest of mine, and I have done some research in that area. And also for my work in the neonatal unit, I have had some interest in perinatal bereavement and palliative care as well.
All right, excellent, thank you. So I want to start by talking about this concept of harm and harm reduction. And I want to make a distinction between what we're discussing here today and what's known as the clinical theory of harm reduction. The clinical theory of harm reduction is really focused on primarily, public health policies related to substance use and very specific practices to, reduce the amount of harm that comes with, risky, drug use and also sometimes with sexual behavior and practices. What we're talking about here today is much broader. We're talking about harm and harm reduction in the context of bioethics. And certainly the types of issues that emerge in the clinical theory of harm reduction are part of harm and harm reduction, but we're going to be talking about something wider. So, in bioethics, we kind of have guiding principles. One of the guiding principles of bioethics is non-maleficence, do no harm. And it's this basic kind of moral principle that any harm that's caused in a healthcare setting should be offset by an anticipated benefit. So there should not be any harm that's just caused for no reason. But there's, in ethics, there's always open questions that emerge, right? Nothing is ever clear-cut, or very rarely. And so there's this idea of, how do we define harm? What constitutes harm? And also, how do we balance kind of an emphasis on, in healthcare, there's often an emphasis on physical harm, but we have these wider scope of harm, emotional harm, mental harm, spiritual harms that can occur throughout healthcare practice. And also, harm is understood and harm reduction as a key component of, social justice as part of medicine and the distribution of care. So my first question that I'd like to put here for the panelists is, what are examples of harm or risks of harm and efforts to reduce, prevent, mitigate that harm that you've encountered in your own experience? And how does this relate to kind of this expanded conception of harm where we think of harm more holistically? Dr. McLeod, would you be okay with going first?
Sure. I'm glad that you bring this up, this concept of harm or harm principle, particularly with my colleagues in neonatal or in my family nurse practitioner going birth to death. For us, we kind of think about harm in terms of a threshold. That was very difficult for me as a clinician to now translate that into ethics, and you said into the principles. So I'm going to go back a little bit philosophically that I know Kim, you will do even better than me. For us as in ethics, it's the classic trolley dilemma. You have 5 individuals versus 1 individual. If you do nothing, the train is going to harm 5 people. If you take that duty and flip that switch, then the train is only going to harm 1. And when you ask a young learner, of course, what would you do? Save 5 lives or save 1 life? Most of us say 5. And we talk about that in terms of utilitarianism, or giving the greatest benefit to everyone. And of course, we lived through COVID, and we saw that. We've dealt with transplant, we saw that. Life-sustaining technologies, as Anne-Marie said, in the 70s is now different now, where we offer things. And so that idea of I'm going to give the most care, I'm going to give the most technology, I'm going to affect the greatest number of people, most of us would say is beneficent. Well, there's always a harm as we're doing that. And we always give a lot of care, even if we decide that we're not going to do that extra technology or offer that extra ventilator. And the harm that comes is how people take that journey, how the nurses take that journey, how the other clinicians take that journey, how the patient takes that journey, but how the family takes that journey. Because whatever that journey is, it is in the life and the generations of patients for years. So the harm that I see is the unintended discount of what we call moral agency, the person that has the right to make that decision, and to place that in a different way for our young learners or our students is, I'm a child of the 80s, I love hard banging rock and roll music, right? As long as I'm in this room by myself, listening to it, that's fine. But if that spills over to causing harm to someone else, I don't have the freedom to impose myself on others. That is harm. Every individual has a right with autonomy to live their lives psychospiritually to the best intent, but it cannot cause harm on others. And that's what we saw with COVID, right? Whether it was vaccination or misinformation or the structural racism that was exposed, we saw that even in beneficence, other people are experiencing harm. So how do we stop that harm to others? So I'm going to say that from the ethical point of view without the clinical point of view, because I know my colleagues will then delve more into nursing harm and others.
Excellent. Thank you. Dr. Gardner?
So I'd like to take a different lens on harm and to think a little bit about, in pediatrics, what we would consider to be the harm principle of ethics, which is about the fact that in most pediatric settings, depending on the developmental stage of the child or the teen, parents are the proxy or substituted decision makers for their children. And they often come into opposition with the medical lens on care for a child. And I can share, a couple of examples in a moment. But so I'm thinking of Dykema, who, in looking at sort of what is called like the range or the scope or the zone of parental authority, right? The ZPA, has helped us to think about when parents' perspectives on the care of their children, for example, vaccinating my child or not, making a particular medical decision or not, having my child receive life-sustaining treatment or not, when that is really harm, and when at that point, when there is true harm, meaning compromising the child's health in some way or the child's potential future freedoms in some way, when that will require intervention. So then I'll tell a clinical story about a patient. Earlier in my career, I worked for a long-term care facility for children. At the time, it was called a health-related facility, a HERF. Later, it became a skilled nursing home for children. But in our health-related facility, we had a unit that had very cognitively impaired, functionally impaired children, and I mean very cognitively impaired children. And I think of one little boy who was on our unit who had been very ill newborn, born with a very, very, very severe neurological malformation called an encephalocele. It was a massive encephalocele. And it was quite amazing that this baby survived all this time. And, in having some conversations with the clinicians and also with social workers and those kinds of things, I came to learn that the family had not agreed with the decision to resuscitate the baby at the time. And the burdens of caregiving on the family became so extensive that the parents decided to relinquish their parental rights. And so this kid was a ward of the state, essentially, who was in our long-term care facility. Very difficult to know what the harms were of ongoing care for this baby because he had no way to express his experiences to us. And at the time that I was there, he was about 8 years old. So it was miraculous that he had survived all this time. And that was really due to loving, excellent caregiving by the staff, quite frankly. So, that's sort of, to me, and when you talk about sort of examples and different ways of looking at the idea of harm. And so we have the patient as the stakeholder. We have the family, parents as the stakeholder. We have the clinicians who have a lens on caregiving as a stakeholder. We have, really the society also as stakeholders in this. So anyway, just a different perspective, but I think extending from what you're talking about, the idea of not intentionally creating harm and then considering the risk for benefits.
Absolutely, thank you. Dr. Paraszczuk?
Well, I think, those different realms, physical, emotional, psychological. So that's where I have found the challenge because in my experience, the child, the newborn, which is most often for me, it's been a newly born, obviously not only can't speak for themselves, but not even the parents really know that infant at that point in time. Having also worked in pediatrics, I see some differences, when you have an older child. But anyway, so the physical harm could be to the infant or the newborn. The emotional and psychological harm is to the parent. And you're trying to balance that, when you see this care as being futile, and I use that word, it's probably an old-fashioned word, but was one that's been bounced around in my 47 years of practice. Yet the families, particularly now, I think it has changed over the last 40 years because of the press, really, of what has been out there about these miracle babies, and how this, 450 gram, 23-week, newborn is now, going to college, or those stories that come across the media, and then these parents are influenced by what they hear, and so having to balance that, should we resuscitate this 450 gram 23-weeker, even though the parents are requesting that, and it's, you're kind of, you know, you have those three groups. You have the patients, you have the parents, and then you have the healthcare providers, and, you know, it's then trying to mitigate the psychological and emotional harm, as well as mitigate the physical harm. And you know, it's just very, very difficult situation to be in, and I have been in that situation on many, many occasions.
I think, Kim, I think one of the interesting things about what we're all talking about, and while we're talking about harm, is that for so long we talked about best interest. And when you mention futility, and we forget to say that some of these things are very subjective and very personal. When we look at harm, particularly when, as Dr. Gardner said, we're trying to objectify harm in a way that it's not so subjective. Because that idea about futility, it could be quantitative or qualitative. So in my own personal experience, losing my parents, quantitatively, I knew that there was a day that they had life that was going to die. But qualitatively, we just wanted them one more day. So in medicine, how do you balance the subjective, emotional, psychological, spiritual concerns versus these quantitative, cost economic concerns? And for us as nurses, all of those things holistically come into the table. I don't know how you feel about that.
Yeah, I mean, I do agree, because I think one of the challenges that we all face, and you said that so clearly about, you know, those miracles, which are really pretty much outliers. You know, if you think about, you know, where most people land in terms of their health care, I mean, but it's all it's probability. Nothing is 100%. We can't predict with any degree of certainty how any individual is going to respond to any type of care, therapy, resuscitation, treatment. And you do have those, you know, babies or older adults or people with very severe terminal illnesses who do turn around, and it's very hard for us to understand why one will have a positive and the other will not, or in terms of newborns, right? You know, I mean, the long-term outcomes are all dependent on how much of a cranial bleed there is, right? So which baby is going to have a really bad bleed and periventricular leukomalacia, and which are not. We can't predict that. We can just give probabilities, you know, the likelihood out of 1,000 patients, this is likely to happen, you know. And I think parents, as you said, or family members hear these other stories. And who wants to be the one to decide, don't resuscitate my beautiful, perfect, tiny baby? Or, yes, let my, you know, parent whom I love so dearly, let my parent go today as opposed to tomorrow. You know, I'll share a very similar story, quite frankly, Dr. McLeod, which I remember when my own mother was passing away. And I was the only one in the ICU at the time. My brother and my sister had gone home. And I saw her, you know, vital statistics starting to change. And I knew, you know, this is bad, this is the end. And I had to sort of make the decision alone. Should I call someone in and say, put the endotracheal tube back in, you know, give her more oxygen? Or should I just kind of stand there, right, and let it happen? So it is all about the meaning. And I think statistics at that point would have not made any difference, right? So I think that was such a great.
Thank you. I have one follow-up that came to mind as you all were talking. It seems that some of these issues that emerge, you know, another guiding principle for bioethics is the principle of autonomy. And, you know, there's a lot of emphasis on, you know, patient choice, patient self-determination, either the patient or their surrogate decision maker, whether that's the parent or the family member. And sometimes what the patient wants can be harmful. You know, I'm thinking what Dr. Gardner was talking about, or, you know, sometimes what the patient desires, you know, can be harmful either to themselves or to others. You know, but there's also this question of, you know, harm can also be a violation of autonomy, right? So sometimes it's just the patient not, you know, not being able to determine their own care in some way. That is perceived by them as harmful. So it's a very delicate balance, you know, this emphasis on patient choice, patient autonomy, but also on preventing harm to this patient and to the other stakeholders. Do any of you have any follow-up thoughts on that point in particular?
Well, again, I think I'll just think about if you're a parent, or you can think of your own parents, and if someone who's external to your own personal family experience, cultural experience, personal experience, knowledge of your infant, however you may have come to that knowledge, whether it's, you know, through gestation or through, you know, your child growing up in your family, to have an external person perhaps suggest that your decision making is not the proper decision making, that's harm in and of itself. And so that whole idea, you know, I think the ideal, of course, is it's a partnership, it's a joint, you know, collaboration, it's understanding each other's perspective, the clinician's perspective, the provider's perspective, the family member's perspective. That's the ideal, but we know the ideal is not always achievable. But, you know, so there is a harm in that. I mean, one could make the argument, really, that, you know, if as a clinician, the clinician doesn't agree with the parent's decision. And there are so many, you know, like classic examples of that, the Jehovah's Witness refusing a blood transfusion for their infant and those kinds of things. And what is more critical, you know, our lens on it, the right to an open future of this child who needs a blood transfusion versus the family member's point of view that, you know, we're condemning this child to, you know, the inability to have any kind of salvation. I mean, there are all kinds of examples of that, but I think, you know, at the kind of reducing it to the least common denominator is that idea that someone is intruding into your autonomy, whether it's autonomy as an individual patient making a decision or whether it's autonomy as a family member or a parent.
Yeah, no, I totally agree with you. I'm going to take it from the perspective of some of the other ends of life, which are people with chronic illness and being elderly. You know, at some point in time in our lives, we all lack the ability to speak for ourselves. And of course, when we're neonates or children, that is true. But there also becomes that time as we get older that maybe we have diminished cognition or diminished capacity. And so what I see from the other end and being, you know, in palliative care is that people say, oh, now you need a guardian to make your decision. And so we've had many cases of patients refusing surgical interventions, refusing certain life-sustaining treatment, but yet they have dementia. So I think the other part of harm and this threshold, and what frankly gives nurses and physicians and social workers moral distress, is that we want to intervene. We want to do what's good for people. And we know that when we're doing that good, that there could be an unintentional harm, particularly that we could be coercing you or compelling you. And as Dr. Gardner said, we want that to more be shared so that we are giving you some sense of directive counseling and sharing in the decision making. So one of the things that I think the harm principle from Dykema, even though pediatric, that we bring to adult, is that clearly when something is wrong, we shouldn't do it. If I'm sitting here right now and substance abuse and mental illness is a big issue, and I'm saying, you know, I've got a little arthritis now in my 50s, I want you to give me fentanyl. Clearly that's wrong. Clearly clinicians should participate in that and should help me. But then we have the other end, when clearly it is right, and maybe not right from a medical sense of view, but right from your religious point of view. Not children being Jehovah's Witness, but if I were Jehovah's Witness and chose by my faith, or being Catholic, chose by my faith to do or not do something, the healthcare system can't tell me that my faith and my religion is wrong. And so those are opposite ends of the spectrum. And unfortunately, I think most with our experience with neonates or children or novel illnesses like COVID, they fall in the middle. And we call that a gray zone. And when it's gray, then that's when I believe patient autonomy does have much higher role. And that's why we exist in ethics, to really investigate that from all stakeholder perspectives and not to leave out the psychospiritual perspective. That is an important stakeholder. And not to also leave out society, and that's our religious community, that's our other community stakeholders, but also not to leave out what we call the quadruple aim, that what I'm seeing in nursing is burnout, because I'm very distressed at not being able to do what I think is the right thing. So all of those tables, all of those perspectives, as Dr. Gardner said, needs to come to the table.
Absolutely.
Yeah, you know, autonomy has always been an interesting concept for me, working mostly with, you know, very young children primarily. So leaving, of course, the decision making to the parents, and you know, because I have really firmly believed in family-centered care, the shared decision making has also been something that's very important to me. And again, that balance between the infant, child, and the parents. But you know, I think of a situation that I was in where we had a somewhere between around 18 months child who choked, and you know, was anoxic, and you know, was ultimately resuscitated, so the heart was beating, but was really actually met brain death criteria. And so because this child met brain death criteria, they were asking the family to take the child off the, you know, life support. And, you know, the parents initially refused because they were deeply religious and they believed, you know, they were praying, their family was praying, their congregation was praying, everybody was praying that this would change, that the situation would change. And, you know, so to some extent there was a little bit of friction there because, you know, the health care personnel were saying, you know, this is sort of harm for the child, but yet, you know, we had the parents clearly stating that they were not willing to do this. And so it went to the ethics committee in the hospital, and really what they just needed was more time. They just needed more time. And so ultimately what we decided was we would just, you know, keep the life support going. And, you know, actually it didn't even take that many days. It was just within a few days, and they made the decision.
I mean, there are just so many dimensions of potential harm that you brought up there. Because there's the sort of feudal care aspect of it, right? That it is very challenging for clinicians, for nurses, to be doing things that we believe may be imposing pain, discomfort, you know, difficulty of one sort or another on our patients, and we've all been in that situation of having to do that without really knowing what the outcome will be. Being in that kind of situation, one wonders, is that child experiencing any pleasure, right? That's another question. And then we have the other pieces of it, which is when you look at what are the opportunities and challenges for families when children do have long-term, you know, functional challenges such as, I wouldn't say brain death, but when you know, a child or a family member is very cognitively impaired, is medically complex, you know, and it becomes very difficult to know how much pleasure, you know, what is the quality of life You think about a child who maybe has never tasted anything delicious, or you don't know if your physical care of the child is creating pleasure or pain for that child. And then, what are the conditions in our society that would allow the family to continue to provide care without really collapsing the family at the end? And there's all kinds of information that suggests that it is very challenging for families. So there's so many different potential harms that come in that kind of situation. So, but the time piece of it, and clearly, I shouldn't say clearly because I wasn't there, but it sounds as if there was a partnership. There was a good relationship between the family.
Yeah, because this wasn't just solely medically complex, cognitively, impaired. This, toddler actually, had met brain death criteria. So,
but even with that.
But the family needed, in order, we talk about that balance, and the different dimensions, to have taken that child off the ventilator at that moment when the parents were saying no, because they believed that that God was going to make something different happen, would have been harm to the parents, not just the parents, it was a very large extended family that was involved as well. So, that balance and finding that balance and allowing the parents, to have the autonomy to say, this is what I want for my child, whatever that decision is. And the constant, keeping them informed, which I think is crucial.
What do you think would have happened if the parents hadn't come to that decision?
I don't know. I know there was a lot of, discussion on the healthcare side, because I was on that side. So, some of that is like, that these parents, what they were doing to this child, and there was just a lot of
discussions on both sides.
Right.
What I love about what you said is that there's a tincture of time. And I think now in our society, we've moved away from that idea that there's communal time or things are temporal in nature. And I can't help but think about my own research and Dr. Gardner's research and your research. So I'll tell you that what my dissertation was really about readiness, something that I called advanced planning preparedness, and looking at the factors for readiness. And what we see is that readiness is very iterative and temporal, and that communication, whether it's just routine discussion about prognosis or end-of-life communication, goes back and forth. But as I was listening to you, Dr. Gardner's voice was in my mind, even though she's sitting right here, because I think the harm that we talk about is the child is dead. The meaning of that death is very different depending on what our religious background is. There's many other people with different meanings around that word death. So as a nurse and as a nurse practitioner, clearly that child is dead. And my own moral beliefs, I'm still looking for a miracle. Mm-hmm. There's the nurse in me saying this needs to stop. There's the person, the moral agent in me that's saying, I hope the miracle happens. And I'm thinking about Dr. Gardner's research around informal caregiving, because caregiving is going on there. That child's life is gone. But if you could talk about that, Dr. Gardner.
Well, I will tell you about a study that my colleagues and I did in Pennsylvania, where we interviewed aging caregivers of aging individuals with developmental disabilities. And we were interested in future planning. These were home-dwelling, aging adults with developmental disabilities who lived with their families for at least part of time, during the week. Some had some partial respite care where they might be in an institutional setting or a group home for a few days of the week, and then they would come home on the weekends. And it was very interesting to hear the stories of the parents. It was primarily mothers, quite frankly. I think, about 15 interviews. I think I interviewed one father. Primarily mothers who were doing the caregiving, and the adults ranged in age from 35, 40-ish up until 65. A wide array of different economic, resources and so forth, and all kinds of different educational backgrounds. But a few themes that crossed over all of these families, about caregiving. I care for my child. I love my child so deeply. When I am not here, and there's a professional caring for my child, who will love my child so deeply and be so invested in my child, really it's an adult, but in my child, so that I can feel confident that nothing will happen to my child. And then they told me all kinds of very interesting stories about the strategies they used to get aides, workers, clinicians of all sorts to know something about their loved one as an individual. And that was one of the reasons that they did not want their children in any kind of institutional settings, because they were very fearful. Yet, they also talked about the massive, really social conditions, not so much their emotional burden, because, and this is true in the literature, and I think we've all seen this with patients, that many times caregivers, it's an iterative kind of thing, and they receive something, from their ongoing care of their loved ones. It's not just all give, that they feel, satisfied, they grow from this in different kinds of ways, spiritually, emotionally, they're enlarged in some kind of ways. But the social conditions, and that's in literature as well, made it very difficult for them to care for their children. Varying resources, categorical determinations as to whether or not they could receive services. And by categorical, I mean, what's your diagnosis? And how bad is your diagnosis? Opportunities to receive services, but the services are not available in the society. I'm just kind of thinking about those kinds of issues. That there's a very interesting study. I read it during my dissertation a little years ago, but it stuck with me. It was a study by Larson. She studied a group of women caring for their developmentally disabled, cognitively impaired children, teenagers and adult children in South America. Different culture than the United States. Very, sort of a home care kind of environment that, not as much institutional care as we may have had in the United States. And all these mothers, it was all mothers who were the primary caregivers, talked about sort of the tension between reality and hope. That the nurses and the doctors would say, come on, stop denying, your child is never going to get better. You've been caring for this child for 10 years, 20 years, you haven't really seen much progress, accept it. And the mother is saying, but I have to have some kind of hope that there's meaning in this. That what I'm doing has meaning, that it's helping in some way, or I couldn't go on. I couldn't go on doing it.
So, thank you. This is very interesting. I want to move the discussion to talking about harm reduction, specifically in the context of Catholic hospitals in particular. Catholic hospitals care is guided by the ethical and religious directives, which are known as the ERDs. And there are a lot of benefits to receiving care in a Catholic setting. There's a very strong emphasis on kind of the inherent dignity of the person, an emphasis on the holistic kind of well-being of the entire person, caring about the spiritual, psychological, emotional dimensions of the person, advocacy for the poor, the marginalized, the victims of discrimination. So there's a lot of benefits to receiving care in a Catholic setting. There can also be tensions with the ERDs. Many times those tensions can be related to beginning of life issues when it comes to contraceptives, or even just dealing with fertility, infertility, or end of life care. A lot of times those issues emerge there as well. And sometimes these conflicts emerge because everyone receiving care in a Catholic facility might not necessarily have Catholic values themselves, and everyone working in a Catholic facility might not also have, Catholic values themselves. If everybody working and getting care in a Catholic setting, abided by Catholic values, those conflicts probably wouldn't arise, but sometimes they do. And so I want to think about this conception of harm and harm reduction, specifically as it relates to Catholic settings. And if any of you could speak to your experience, if you have any examples from your time providing care in Catholic settings where those values in particular cause some type of tension or just some type of maybe dilemma related to harm and harm reduction.
So I guess I am going to be more ethically philosophical. I think my children always ask me, Mom, you've done a lot of things in nursing. You're a family nurse practitioner, you're acute care nurse practitioner. Why be an ethicist? And I'm going to take myself back to being 6 years old. I'm going to take myself back to 1972 and 73 and say I was the generation of watching television. There's one very important thing being a New Yorker is that on the weekends there were two reporters, Geraldo Rivera and Melba Tolliver, Eyewitness News. They were people of color. And I think about the 70s, and then later if we talk about the 1980s and the Presidential Commission, that we saw this idea of sanctity of life play out on television every day. Now, of course, we could also talk about that the Vietnam War was also being beamed in that time. But I bring us back to that historical point of view to get to a philosophical point of view. And for me, the quintessential reason why I'm an ethicist, one, is that right in Staten Island and Willowbrook, there were children that had developmental delay that now we would think as high functioning with Down syndrome that were injected with hepatitis C. And the squalor came through. And two, there was a young girl in New Jersey who ended up in a persistent vegetative state called Karen Ann Quinlan. And most of us forget that the issue was she was on a ventilator, she was in a Catholic hospital, and her parents argued about Roe v. Wade, that if Karen had been pregnant, she would have the right to determine what happened to her unborn child, and as such, she had the right to determine what happened to her life. You mentioned that, Kim, that for individuals that are Catholic, the sanctity of life is very different. And Karen Ann Quinlan was moved from that hospital. She was given another option. She was allowed to be removed from a ventilator. And for me, as I was becoming a respiratory therapist in 1986, one morning I'm ironing my clothes to go to my alma mater, and Karen Ann Quinlan died. And she died many years later. Feeding continued, and she had an NG2. Those two things are very close when we talk about the EDRs. The idea about reproductive health, the idea about nutrition, the idea about the sanctity of life. And one of the things that I'm grateful for as an ethicist is that we work with chaplains, and chaplains are very non-denominational. The overall tenet of the sanctity and dignity of life is something that everyone holds dearly. And I think the beauty of Catholicism or Catholic hospitals is that idea that you don't have to be Catholic, but we do have to have a conversation about what it is for morality, and we have to include people. Now, I work for a non-secular health system. You mentioned that. And I think some of the things that we do well or we don't do well also involves just these very principles of what people hold dear. Trust is the most important thing. And I think having that trust and knowing that we're going to respect your dignity prevents harm. But then what could be the harm is that as clinicians, we need to have conversations about other options. So if you are not Catholic and you do have this issue about reproductive rights, that there are other options. But we know even the Catholic Church has updated the EDRs. So it is not against the sanctity of life to have conversations about the end of life. It is not against the sanctity of life to have conversations about enteral artificial nutrition. It is against the sanctity of life to do anything that causes the death of someone who would not ordinarily die. So no physician aid in dying, no withdrawal of life-sustaining treatment when it can save life. But when it's futile, even though we don't use that dirty F word, then there's an opportunity for conversation.
Well, first of all, I want to say that, that's what I think the foundations of the EDR, of the ERDs, the ethical and religious directives, are something that are, they're grounding principles for nursing too. Those values, human dignity, people's rights for, loving care, what would come from my kind of cultural background, tikkun olam, healing the world, being concerned about the world. All of those things are things that I think are the foundations of nursing practice and nursing values as well. So there is, what I like to tell students and what I have done myself from my own cultural background is to pose the question. We work at an independent Catholic university. How do I fit? How do I fit? How do I fit if I'm Catholic? How do I fit if I'm not Catholic? How do I fit inside that mission? And then how comfortable am I with the way that I fit? And so I think that's something that we try to help our students to understand when they're making their choices about their post-educational careers, and that there are a lot of alignments among those values. But some clinicians may be more or less comfortable being able to direct people to options as opposed to offer those options more directly themselves. And so that is an important question that clinicians have to ask themselves. So you asked for an example, and this is an example of not from my experience working in a Catholic hospital, but receiving a patient who was transferred from a Catholic hospital. This was, again, a neonate who had a very severe brain abnormality and was not going to survive, who had been born and resuscitated in a Catholic hospital in another state. And, as the diagnostic process went on and the various diagnostic tests, were done and so forth, being very clear that the baby was not going to be able to survive and was dependent on, life support in a way that we don't view life support in the same way in the NICU sometimes, but this was truly without the ventilator. The baby was going to die, was on IV hydration and all these kinds of things. And the parents made the decision that they felt it was in the best interest of the child, taking into account all the various considerations. I don't remember the family's religious tradition at the time, that they wanted their child to be removed from the ventilator. They wanted to be able to hold their child and care for their child and allow the child to die naturally. So the baby was transferred from a Catholic hospital to our unit. I was a very new graduate at the time, and I don't really think I fully understood all of the implications of those things. But I do remember an extensive amount of conversation with the families about pain, how much pain the baby might be in, and so forth. And I think about the other sort of piece of this story, which was about how the parents may have felt having to leave all these relationships that they had established with people at the initial hospital where their baby was born and resuscitated and cared for and so forth, and come to a place of strangers where their baby was going to die. So that's an interesting, I think, take on the idea of harm and the options. The ethical and religious directives, as you said, Dr. McLeod, allow for the removal of fetal treatments, but not for the removal of nutrition and hydration and those kinds of things. And that was a choice that the family wanted to make, to be able to allow the baby not to linger, I guess you could say. So, thank you.
So my experience, so I have never actually worked in a Catholic hospital, but I have taken students for maternity rotation in a Catholic hospital. So there was one experience when there was a mother who had peripartum cardiomyopathy, and fortunately she survived. Women who have had that once are recommended to never get pregnant again. So it was very much a experience for the students, because we had discussed the condition and all the implications, and then being in a situation where they could not share with this woman that not that they were going to do it per se, but that the information about contraception could not be shared with this woman, and that was something that I found the students to be grappling with, because a subsequent pregnancy, actually this wasn't her first pregnancy, she had one pregnancy before this, but then had the issue with, I think, the second or a third pregnancy, but the thought that a subsequent pregnancy could kill her, and yet there was not that conversation about how to prevent a subsequent pregnancy was, other than, the natural way, was very upsetting, actually, I have to say, quite honestly, was very upsetting to the nursing students. Of various, they were all of, I had a full group of 8, and they were various religious backgrounds, ethnic backgrounds, and, by and large, they were very, very, very disturbed. And, as I probably was also being, myself Catholic, but yet saying this, another pregnancy could have very, very, very serious consequences for this woman. And, but, one of the things that I have found, and again, it was really more of my experience taking students to a Catholic hospital, is that I oftentimes don't think that the consumer, that person who's coming to the Catholic hospital, knows about those ERDs. Correct. I don't know if they're always fully, some are. I mean, some people are, because I have actually had, women say to me, I wouldn't deliver in a Catholic hospital because of certain, directives. But by and large, I'm not sure that they are aware even sometimes when they, end up in those. And sometimes it may not be by choice that they end up in a Catholic hospital, obviously, but, I know sometimes if you go by ambulance, it's to the closest. And whatever that hospital be, but sometimes they're making the decision, I like this obstetrician and he delivers here, and they're just not cognizant of all the other ramifications.
And sometimes, I grew up in the rural Midwest, and sometimes the only hospital for miles around is actually, a Catholic hospital. And again, you don't. Yeah. Many patients going there aren't aware of the ERDs.
Yeah, I think that we're bringing up a lot of issues talking about moral injury. And what's very interesting for me from the perspective of ethics, and I think that that's why we're so grateful to have chaplaincy that's so multi-denominational, is that we've mentioned Jehovah's Witnesses. Of course, we're here talking about harm in Catholicism. And I think it's that multiple perspective of the harm of the individual not understanding fully their options or opportunities, or feeling that their moral choice is at odds. I think we're going to see this a lot more, not only as we talk about Catholicism or Catholic churches, as we talk about non-secular churches, as we talk about society and politics. And each of us have been in healthcare for now many decades, and where we saw people being treated in the 80s very different than the 2000s, which is very different than we're coming up in 2030. It would have been unheard of for myself as a young nurse. I remember the most difficult ethics case I had as an ethics fellow in 2010 was an infant that the attending, who was a palliativist and a geriatrician, told me the negotiation that we're having is to remove gavage feeding from a neonate. And I immediately, my own personal self, whether it was my own morality, whether it was my own religion, or just frankly, the culture that was strongest at that moment was being a nurse, said, Dr. blah, 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 you never remove gavage feeding from a neonate. Am I wrong? That's the way we were raised. And he gave me a lot of evidence-based things. And I said, I hear you. Scientifically, I hear you. But I am not going to negotiate that alone. If we're going to do this, you're going to be with me having this teaching with the nurses and the physicians before we even begin to approach the parents. And so we find that whether it's reproduction, nutrition, life-sustaining treatment, that's where this moral injury, moral distress comes. And frankly, that's where we hit the ERDs, right? Because we all have this feeling of what ethically is right to give a patient. And then that harm comes to the clinicians. We're not sure whether the harm comes to the patient, but for us, we want to give that patient fully informed consent so that they can make an autonomous wish. And we know that even when people are staunchly religious, not everything that we do is aligned with the religious tenets. And that's one of the things that I would say in this space is where is the outlet for that moral injury or moral distress from the point of the patient, the young nurses, the clinicians.
Yeah, I mean, it's interesting when you think about the moral side of it as opposed to the ethical side of it, because moral, the moral injury and moral distress is much more engaged with your own particular value system than principles of ethics, which, we try to think are separate from our moral perspective, but they're not. And I think you said that your value system is always at play. And so how do we help young nurses and young physicians and young clinicians and our students to understand, there is your moral response, there is sort of the ethical underpinnings, right? Those are the things that can help us to make, to take steps to make a decision or to help the client to make a decision. And then the need to not impose your own value system on the situation. And it's so incredibly messy and so incredibly painful in many ways. And that it's very challenging, and that's why it is so messy. I would just say, when I think about that particular situation, and by the way, I had my children in a Catholic hospital, which was very wonderful because there was a lot of attention to my spiritual, the spiritual, domain of my personhood, I would say. It was very beautiful, but interesting other kinds of issues around that. But because I've lost my train of thought a little bit. So, well, anyway, maybe it'll come back to me.
The moral.
Oh, the moral, yes. So, yes, and so when I think about that situation with that baby who was transferred from one neonatal ICU to another, and another, and another state, and so forth, is that the sending hospital made every effort to understand and acknowledge the family's situation. It wasn't imposing a particular religious perspective on that family. It was understanding where the family was in their decision-making process and then helping them to create an opportunity to allow that to happen because it didn't fit into Dykema's home, So, I think to me that is the critical underpinning of, the way that care is delivered in Catholic hospitals, is respecting human dignity, that foundation, how that's interpreted and maybe how it's operationalized across different hospitals in different states with different, religious leaders who are interpreting these things, that perhaps there's variation in that, but I do think that that foundation of recognizing people's dignity as human beings, or children's dignity as human beings, is something that I see in the Catholic hospitals. Although I might not necessarily agree politically or agree, in terms of my own religious tradition with some of the ways that the decisions are made, because there are definitely different views on the mother versus the child, or whose life should be saved first, and those kinds of things. I mean, there are very different perspectives on that, depending on what tradition you may come from, or no tradition. Which is
Absolutely. So this has been a wonderful conversation. We're at a little bit over an hour, so I think we need to wrap up. I want to give you just, if you have any closing thoughts that you'd like to, just want to give an opportunity. Don't have to.
I'll just say, I think from my own point of view, having this conversation among three of us who are nurses, but really come at our lens is a little bit different, and I think it's been very valuable for me. Really, it's been a learning opportunity for me to hear from my colleagues and have this very deep conversation about what harm may mean and how harm may play itself out, and what we do to try to mitigate harm as much as it's possible to do so. So it's been a joy.
I have to say it's been an absolute joy, and I think to anybody that's been able to hear us, or in future hearing us, this is difficult. Harm is different to each of us, and there's always a harm. I mean, as wonderful as this couch has been, and it's been so soft, and it's been so good, and it's been such good conversation, the harm is that I'm not going to want to get off this couch, right? And so that's always there, thoughtful people with multiple perspectives, really trying to help balance this idea, and it is a balance.
Well, I agree that this has been, I was petrified coming here, I'll be the first to admit it, because I'm not an ethicist. I don't have any of that background formally, other than, many years of experience working in healthcare. And so this has been a very interesting experience, and this interchange has been very helpful for me. And I think about it, sort of putting my faculty hat back on and thinking about the students. And, I do myself try to bring some of my experiences into the classroom, to kind of highlight for them that it isn't always, right and wrong, black and white, it's this side or this side, that there is, this concept of harm. And I haven't really maybe described it in that way, but, that some way somebody's going to oftentimes be more negatively affected than others. And, I think that that's really, really important, because I know myself, when I first graduated, a lot of this was not discussed in my education. It was all, the pathophysiology and all really, the curative. I didn't go to a Catholic college, so, and, I was not long out of school when I had, experienced my first neonatal death. It happened to be Christmas Eve. I was working Christmas Eve, and I was so ill prepared in terms of being able to help that family. And so, I try with the constraints of time to be able to share at least some of this with the students, so that they at least realize that there's this aspect out there that they need to really be aware that there are gray areas, for sure.
Absolutely. I think conversations like this are incredibly important for, you know, students, people who are going to be clinicians working in the field, working with patients. You know, this conversation about values and, you know, how that influences the delivery of care. I think that's a really important to mention, and it's great that we can have a conversation like this on our campus. And I think this has been excellent, and I want to thank all three of you. I want to thank everyone in the audience for attending. And also, I forgot to say at the beginning, you know, this is put on by the Philosophy Department and the Center for the Social and Ethical Concerns. And also, it's sponsored by a grant from the Lilly Fellows Program. So we want to say thank you to them as well for helping make this happen.